Hello guys, welcome to Ankit Sunyalvits. Today I'll tell you how to take perfect history and how to do perfect examination for thyroid. Before that, I would like to discuss some basic diagnosis with you. The most common could be goiter. Goiter is a generalized enlargement of a thyroid gland. Goiter could be of various types like simple goiter, toxic goiter, neoplastic, thyroiditis, and another common diagnosis would be a thyroid tumor. Thyroid tumor could be of benign or malignant. Generally, benigns are rare. Malignant would be more common. Malignant is again divided into three types of carcinomas: papillary, follicular, anaplastic. Another one is medullary, which arises from parafollicular cell, and the another one is lymphoma. So here is Dunfield classification of malignant thyroid you can go through. So this is the basic criteria. How do we differentiate between papillary carcinoma, follicular carcinoma, medullary carcinoma, and anaplastic carcinoma? Here we'll start with history taking. In history, first thing is for name, for identification, then is the age. Age play a vital role because age can tell you a lot of thing about the disease, like a simple goiter seen in teenage girls and also during the pregnancy when there is a disbalance between the hormones. Anaplastic carcinoma is there in old age, papillary carcinoma is there in young age women. Then is the gender. Obviously thyroid problems are more common in female. Thyroid carcinoma is approx 3 times more common in female. Thyrotoxicosis is 8 times highest in female. Then occupation is required because primary toxic goiter is more common in unbalanced psychic condition. Education is important to know how much the patient can understand about his or her own illness. Here the address is very important because this will tell us if the person belongs to hilly area where endemic goiter is very common due to iodine deficiency in the hills. Next section is chief complaint. Here you have to talk about for which complaint the patient came to the hospital. Mostly it would be swelling in the front side or the right or left side of the neck. Try to avoid words like left lateral or right lateral of the neck. Most of the examiners do not like. You have to write the duration of the illness. Simultaneously, if the patient have 2-3 other complaints which can be put up as chief complaints, then you can put like pain or hoarseness of voice or difficulty in swallowing or breathing, or if the patient have come for bulging of eyes or any other complaint. Then is the history of illness. History of illness can be written in two ways here. If the patient have come for the first time, you can write it like patient was apparently well this many months back when he or she noticed a swelling in the neck while taking a bath. If the patient have already taken some treatment, so the another way of writing is you can give a short brief about his past history, like patient was diagnosed with thyroid carcinoma, probably a papillary carcinoma, 2 years back, underwent a hemithyroidectomy. Now the patient have again presented with the swelling in the neck for past 1 month, and then you go with the present history. So this is just a brief because this past history would be again dealt in the past history column, but just a brief, so examiner is aware that the patient have come for the second time for the reoccurrence. So then when you present your history, examiner can relate to it. So in the history of swelling in the neck, you have to ask how was the onset, sudden or insidious, where is the swelling, front and which side of the neck. You have to ask the duration, you have to ask the rate of growth and progress in size. Generally benign swelling will have a gradual increase in the size and rapid increasement in size would be there in with malignant swelling. You have to ask whether it is associated with pain or not. Differential diagnosis related to thyroid swelling, like if there is a sudden onset of the swelling with pain, so the common diagnosis would be thyroiditis. If there is sudden increase in size with pain, then the cause could be of hemorrhage or suddenly the swelling have changed from benign to malignant. Slow growing swellings are papillary carcinoma, follicular carcinoma. Fast growing are anaplastic carcinoma. Simple goiters are generally very slow. Multinodular goiter or single nodular goiter or colloid goiter, generally the increase in the size of the swelling is less. Generally in a year they grow. Then if the patient give history of pain in the neck swelling, then you have to ask about the duration and site, nature of pain. Usually it is dull aching. Is there any radiation to pain, aggravating or relieving factor, associated with fever or not? Because if it is with fever, then the diagnosis could be thyroiditis because inflammation is painful and all the goiters would be generally painless. But malignant swellings can also become painful in later stages. So they will ask you what is the differential diagnosis of pain in the thyroid swelling. So pain in the thyroid swelling can occur because of hemorrhage, more common in hyperthyroid patients. Pain can occur in malignancies which are infiltrating the nerves. Pain can occur in thyroiditis or anaplastic carcinoma or if the patient have undergone a FNAC investigation. Post FNAC also patient can complain of pain in the thyroid swelling. Then you have to ask the history of pressure effects. When thyroid compresses the trachea, the air passing through the narrow trachea will result into stridor. The causes could be trichomalacia in long-standing multinodular goiter, or retrosternal extension of the thyroid swelling, failure due to secondary thyrotoxicosis, or infiltratory anaplastic carcinoma. You have to ask whether there is any history of hoarseness of voice, which can be due to infiltrating of recurrent laryngeal nerve by malignancy, or due to edema of vocal cord. Is there any history of dysphagia? If there is history of dysphagia, more to solid or to liquid. Dysphagia can occur during the first stage of deglutition when thyroid moves up, so it can compress over the esophagus. Generally, it is said it is very difficult for the thyroid swelling to compress because it stretches. If the thyroid is putting a pressure over the carotid, then it can result into syncope. You have to ask the history of Horner syndrome, because when thyroid compresses over the sympathetic trunk, then it can result into ptosis, meiosis, and hydrosis, the Horner syndrome. Next is you have to ask the history of hyper or hypothyroidism. It is very important to assess the status of hyper or hypothyroidism clinically, because if you are sending the patient for FNAC or some other investigations, if the person is having hyperthyroidism, then the person is at risk of thyroid storm or thyroid crisis, which could be very dangerous. Thyroid storm or thyroid crisis is a state of hyperthyroidism where it is aggravated generally by infection, surgery, or minor trauma. So you have to ask the symptoms of thyrotoxicosis. Common symptoms are excessive sweating, loss of weight in spite of good appetite. You have to understand the person is having a good appetite, but despite of that he is losing weight. You have to ask history of any heat tolerance, any diarrhea or amenorrhea. Thyrotoxicosis could be generally of two types: primary and secondary thyrotoxicosis. Primary thyrotoxicosis means thyroid swelling and the toxic features appear simultaneously. For example, in Graves' disease. And in this, the clinical features would be of like above the neck, means in this the patient will have symptoms of CNS and eye. Secondary thyrotoxicosis means the patient will have a history of long-standing thyroid swelling, then the feature of thyrotoxicosis will occur secondary. The means first is the swelling, then after the gap thyrotoxicosis will occur. So example is toxic multinodular goiter or solitary nodular goiter. In this feature would be generally of cardiovascular system. So in history of primary thyrotoxicosis, you have to ask whether there is tremors of hand or insomnia. Generally patient will complain of sleepless nights. There will be proximal muscle weakness. It means there will be difficulty in climbing stairs, or there will be difficulty in standing from the sitting position. Generally in India, if the person belongs to middle class or poor family, then the patient will complain like when he sits in Indian style toilet, then he's unable to get up because there is proximal muscle weakness in the thigh. In eye, the patient will have exophthalmos, difficulty in closing eye, double vision due to ophthalmoplegia. Ophthalmoplegia means weakness of eye muscle. There could be pain. Severe symptoms may not be that prominent. In secondary thyrotoxicosis, there will be cardiovascular symptoms like palpitations, ectopic beats, arrhythmia, dyspnea, chest pain, edema of ankle, congestive cardiac failure symptoms. So then you have to ask the history of hypothyroidism. Here there will be increase in weight despite of decrease in appetite. Means the person is eating less but still he is gaining weight. There would be hoarseness of voice because there is edema of vocal cord. There could be falling of hairs from the scalp. There could be also feature of like 2/3 of the eyebrows may fall off. Patient may have constipation, weakness, lethargy, or swelling of face, leg, or body, cold intolerance, dry skin. Patient may have menorrhagia in starting, but later on may have amenorrhea due to the anemia later on the later stages, but initially may have menorrhagia. Then you have to ask any history of malignancy which have metastasized, history of weight loss, loss of appetite. If thyroid malignancy have metastasized to bone, then the patient may complain of bone pain. For lung, the patient may have dyspnea, cough with hemoptysis. Papillary carcinoma can metastasize to brain, then person may have seizure, neurological focal deficit could be there. Follicular carcinoma can metastasize to skull. Then if the patient complained of history of bulging eyes, then you have to ask what is the duration, what is the progress, Is there any history of redness of eye or watering, or there is history of double vision or loss of vision? Then in the past history, if the patient have already taken some treatment for thyroid disorder previously, then you have to write in full detail what all test was done for the patient, what all drugs the patient took, what all surgery was done. You have to write it full detail. You have to ask any history of diabetes, hypertension, or coronary artery disease, whether the patient is taking drugs for diabetes or hypertension, whether his sugars and BP is controlled or not. You have to ask any history of previous surgery, because there could be reoccurrence of certain malignancy. You have to ask history of irradiation in childhood. Generally irradiation is not done now, but it was previously done for the treatment of tinea capitis, thymic enlargement, enlarged tonsil or adenoid, acne vulgaris, hemangioma, Hodgkin's disease. You have to ask history of long-standing multinodular goiter, which can actually transform into follicular carcinoma in later stage or can result into some toxic symptoms later. Then in person's history, you can ask whether in his diet, if the patient is consuming excessive goitrogens. Goitrogens are the vegetables or the plants which belong to Brassica family, which includes cabbage or kale. You have to ask if the patient have habit of sea fish, because generally sea fish contains low iodine, can result into goiter. You have to ask whether the person is allergic to any drugs. Ask the history of a bowel habit, like generally diarrhea could be a presentation of medullary carcinoma of thyroid, or diarrhea could be there in hypothyroidism also. You have to ask if the patient have taken any drug like lithium or thyroxine or antithyroid or any amiodarine, because these can result into thyroid dysfunction. So drugs are also called goitrogenic because they can result into goiter, like lithium, sulfonylurea. So here are the drugs which can result to certain effects. So thyrotoxicosis, factitia. In this, if the person is consuming excess amount of levothyroxine, that can result into thyrotoxicosis, known as thyrotoxicosis factitia. There is something called JOD, base dose thyrotoxicosis, in which if excess level of iodide is given in endemic goiter, that will result into thyrotoxicosis because the number of cells have already increased in goiter. There is another effect called Wolff-Chaikoff effect. In this, iodides inhibit the further release of thyroxine, which results into hypothyroidism. In female patient, you have to ask the history of menstrual history, because oligomenorrhea could be there in hypothyroidism, menorrhagia could be there in hypothyroidism. In family history, you have to ask any history of goiter, which could be endemic of that particular area. You have to ask any history of thyroid malignancy in family, especially medullary carcinoma of thyroid, or any malignancy like Men's syndrome, multiple endocrine neoplasia, especially MEN2A and MEN2B, which can run in families. Then you can summarize your history based on this age of lady presented with a swelling in right or left side of the neck for past this many months or year, with rapid or slow increase in size, not associated with pain, or no history of pressure symptom, no history suggesting of hypo or hypothyroidism. So guys, let's move on to examination part. First is the general examination. You have to start by saying that patient is comfortable at rest, conscious, cooperative, oriented to time, place and person. You have to comment on build, which is a skeletal parameter. You have to talk about nourishment based on the BMI. If the patient is having the features like mask-like faces, which is seen in hypothyroidism, then you have to mention that. If the patient is having facial expression of excitement or tension or nervousness, which is seen in hyperthyroidism, then you have to mention that. Nourishment of the patient is very important, because thin and underweight type of nourishment is seen in thyrotoxicosis, and obese and overweight is seen in hypothyroidism. Cachexic look and anemia will be present in carcinoma of thyroid. Then you have to talk about pallor, icterus, cyanosis. Clubbing could be there in thyrotoxicosis, also known as thyroid acropathy, or also there in hypertrophic pulmonary osteoarthropathy. There could be generalized lymphadenopathy. Look for pedal edema. Bilateral pedal edema could be also present because of pretibial mixed edema. Then you have to look for clinical features of hypo or hyperthyroidism in the patient. Clinically, for hypothyroidism, you have to look if the patient is obese or the face look little dull. You have to look for dry skin, macroglossia, mask-like faces, loss of hair in the lateral eyebrow, hoarseness of voice, or pseudomyotonic reflex, which is also known as delayed ankle jerk. For the feature of primary thyrotoxicosis, you have to look for eye signs like lid retraction, which is there because of sympathetic overactivity of LPS muscle. You have to look for exophthalmos. Generally, examiner may ask you sometime what is the difference between exophthalmos and proptosis. You have to remember when the protrusion of the globe is less than 18 millimeter, then it is proptosis, and patient can avert his eyelids. When the protrusion of globe is more than 18 millimeter, it is known as exophthalmos. To look for exophthalmos, there are two tests which you can do. One is Gifford test, in which patient cannot avert his eyelid due to molar muscle hyperactivity. The second one is Navziger test. For Navziger test, you have to stand behind the patient, look from behind with the neck of the patient slightly extended, and look along superior orbital margin. Exophthalmos is present when the eyeball is seen beyond the superior orbital margin. There is also a WHO grading, no specs for exophthalmos. You can go through for detail. Like the first sign would be Stellweg sign. In Stellweg sign, there would be starry look with infrequent blinking. So that is the first sign of exophthalmos. The another sign is von Graefe sign, which is also known as lid-lag sign. In this, steady the patient's head with one hand and ask the patient to look at your finger held in front of the eye. Ask the patient to look up and look down, following your finger moving in front of the eye up and down quickly for 5 to 6 times. Normally, the movement of upper eyelid follows the movement of eyeball. In case of thyrotoxicosis, the lid may lag while the eyeball move down. If lid lag is present, the sign is said to be positive. Another sign is Dalrymple sign, in which the upper sclera is visible due to the lid retraction. Fourth sign is Geoffroy sign. For Geoffroy sign, steady the patient's head with one hand. Ask the patient to look up at the ceiling. Normally, there will be wrinkling of forehead while looking up. In case of thyrotoxicosis, there may be loss of wrinkling of forehead. The another one is Mobius sign. In Mobius sign, there is inability to converge both the eyeballs. Last stages of progressive stage where there will be ophthalmoplegia, means muscle weakness, epiphora, keratitis, chemosis. Chemosis means edema of conjunctiva. There could be orbital hemorrhage. Then you have to look for clinical feature of primary thyrotoxicosis, where they will have the eye signs. Patient will have tachycardia without the raise of temperature, because in case of fever there might be tachycardia, so you may confuse with thyrotoxicosis. Then you have to look for tremors. You have to look for tremors in the distal muscles. First, you have to look the tremors in tongue, where the tongue is inside the mouth for approx half a minute. Second is you have to look at the tremors in outstretched hands. There you can see the fine tremors in fingers if the patient is having primary thyrotoxicosis. Then clinical feature of secondary thyrotoxicosis, lid lag and lid retractions are two common signs which you will see in primary and secondary thyrotoxicosis both. Other than that, there will be mostly of cardiac failure sign in case of secondary thyrotoxicosis, like edema of ankle, orthopnea, dyspnea, eye signs, and auricular fibrillation is quite common in secondary thyrotoxicosis in later stages. Pulse may become irregular in secondary thyrotoxicosis, but remember, like, there is no tremor and no exophthalmos in secondary thyrotoxicosis. So examiner may ask why in secondary thyrotoxicosis cardiac symptoms are manifested more than the eye. So answer for that question is, in secondary thyrotoxicosis is common in generally among old age, where already the heart complications are more, so the sympathetic overactivity affects the heart more. As primary thyrotoxicosis is common in young patient and secondary thyrotoxicosis is common in old age patient. Then you have to look at vitals, BP, you have to look at the pulse would be generally there will be bradycardia in case of hypothyroidism, and pulse would be increased in case of hyperthyroidism. Generally for thyroid patient, we have to look the sleeping pulse rate. You have to look at respiratory rate. You have to look at temperature. Temperature is kind of important because if the patient is having fever, then his pulse rate will increase. Just to mention that there is Cryle's grading of pulse rate, in which sleeping pulse rate is measured after giving phenobarbital. Then you have to examine the other systems. First is cardiovascular system. You have to look for any signs of heart failure which maybe suggest feature of secondary thyrotoxicosis. You have to look at the respiratory system for any lung metastasis or any tuberculosis or any other lung pathology. You have to look at abdomen because sometimes there could be lymphoma of thyroid and abdomen. Then in the local examination, first is the inspection. You have to remember that normally thyroid gland is not so obvious in the inspection. For inspection of thyroid gland in obese patient and short neck individuals, you have to use Pizzolo's method. In this, ask the patient to keep her hand behind the head and ask to push head backward against the clasped hand on occiput. So by doing this, thyroid gland become better visible in obese and short-necked individuals. So for the local inspection, first you have to look if you can see any swelling or if the whole gland is enlarged. You have to mention that. Then you have to look about the site, what side the swelling is visible. You have to comment on the size. You have to comment on shape. Just remember, the thyroid gland will look like butterfly shape when both the lobes and the isthmus is enlarged. So diffuse swelling is there, then only you will call the shape as butterfly. Otherwise, if any solitary nodule is seen, then it would be mostly hemispherical. Examiner may ask you what are the differential diagnoses where the whole thyroid gland is enlarged. So one could be physiological goiter, second could be colloid goiter, third differential diagnosis could be Hashimoto's disease. Most commonly you will get a case of solitary thyroid nodule. Just remember that solitary thyroid nodule is not a disease, is not an exact diagnosis. Solitary thyroid nodule means a single palpable nodule in the thyroid on clinical examination. Otherwise, the rest of the gland is normal. So they may ask you the causes of solitary thyroid nodule. This you have to say in the sequence wise, because the most common cause is colloid goiter. The second could be adenoma of thyroid or the dominant nodule of multinodular goiter. Other causes could be carcinoma of thyroid. Most common is papillary carcinoma, thyroid cyst, lymphoma or thyroiditis. Just to mention about Plummer's disease, when a solitary thyroid nodule presents with secondary thyrotoxicosis, means having the cardiac involvement, then it is known as Plummer's disease. In the inspection, after the shape, we have to mention about extent, from where to where the swelling is extending. Then you have to talk about the surface, whether it looks smooth in case of adenoma and grave disease, it looks irregular in carcinoma, nodular in multinodular goiter, whether all the margins are visible or not, especially the lower border of the swelling, because if the lower border of the swelling is not visible, then you have to suspect retrosternal prolongation of the goiter. To look for retrosternal goiter and its extension, what you can do is a Pemberton sign. For Pemberton sign, you have to tell the patient to raise both the arms over her head until they touch the ears. Maintain the position for a while and look for congestion of face or distress. This happens because due to obstruction of great veins of thorax. Like here is the example of Pemberton's sign. After that, in the local inspection, you have to look for any skin changes over the swelling, like is there any scar or any pigmentation. You have to look for any visible pulsation. You have to look for any dilated veins. Generally, if there is a malignancy, so malignancy will require more blood supply through the artery, and to take the blood out of the malignant part, the veins will dilate to increase its capacity. So there will be dilation of veins. Also, when there is retrosternal extension, it will compress over the superior vena cava, which will also result into dilation of veins. Then you have to look for whether the swelling moves with deglutition or not. This is most important. You have to tell the patient to swallow his or her sputum, or you give them a water to drink. Then you look whether the swelling moves with deglutition or not. There are approx 5 swellings which moves with deglutition. One is the thyroid. Thyroid moves with deglutition because of pretracheal fascia enclosing the thyroid attached to the hyoid bone. Also, ligament of Berry, which is posterior medially, attaches to cricoid cartilage, and also isthmus have some attachment with trachea directly. That's why thyroid moves with deglutition. The normal question which any examiner will ask you, why you are saying it is as thyroid swelling, why it cannot be any other swelling like lymph node or a lipoma. So you have to answer that question by saying that a thyroid swelling is recognized by its position, by shape, by the fact that because it moves upward with the deglutition. So the next question of the examiner would be, what other swellings move with the deglutition? So you can say there is thyroglossal cyst, subhyoid bursitis, nodes attached to larynx or trachea or laryngoscope. There are certain causes where it is a thyroid swelling but it do not move with deglutition. It can happen in anaplastic carcinoma or malignancies which have infiltrated or fixed to the trachea. Thyroid swelling is fixed because of previous surgery. There are adhesions now. Retrosternal goiter, readers thyroiditis because of fibrosis. It do not moves with deglutition. Then in the local inspection, you have to look whether the swelling move with protrusion of tongue or not, because thyroglossal cysts move with protrusion of tongue but not the thyroid swelling. Thyroglossal cysts move with protrusion of tongue since the thyroglossal duct extend downwards from the foramen of cecum of the tongue to the isthmus of thyroid. To look for that, you have to fix the jaw with both the hand and then tell the patient to protrude her tongue out, and then you have to also look on stretching the deep fascia by telling the patient to extend the neck. Does the swelling become more prominent or not? The next part is the palpation. On palpation, remember patient should be sitting on the stool. Examiner need to stand behind the patient. Always palpate from the behind first. Patient neck is slightly flexed. Thumb of the examiner should be behind the neck with the fingers should be doing the palpation. So there is another method which is called Lahaye's method. In this, examiner is in front of the patient. To palpate the left lobe, examiner's hand push the thyroid gland to the left. During the palpation, make sure the one hand is there to support and the other hand is there to palpate. So you should not move both the hands together. One hand should be steady, another hand you have to palpate. Whenever there is a doubtful node, like you are confused whether it is a thyroid nodule or any other nodule, then you can do Crayle's method. In this, you have to place the thumb on thyroid and tell the patient to swallow the sputum or to drink water. If the swelling moves up with deglutition, this means it is a thyroid swelling. On the palpation of gland, you have to first look for local warmth and tenderness. Then you have to look for surface, whether it is smooth or bosselated. Smooth would be there in colloid goiter, Graves' disease. Bosselated would be there in multinodular goiter. You have to look for consistency, whether it is soft, firm, hard. Hard is there mostly because of carcinoma or readers. Soft will be there in goiter, in colloid goiter or Graves' disease. Variegated consistency could be there in papillary carcinoma. Variegated means there is some area which is hard, some area which is soft. There is something called thyroid paradox which we will talk in next slide. Before that, then you have to look for mobility, whether the thyroid is vertically mobile or it is restricted because of in carcinoma or thyroiditis. You have to also look whether the swelling is fixed to the skin or not. By pinching the skin, you will get to know whether the swelling is fixed to the skin or not. So talking about the thyroid paradox, generally which all swelling are hard in consistency are said to be malignant and the soft one are said to be benign. But in thyroid, this thing is reverse, because cystic swelling, if it is very tense, so you will feel the tense fluid as hard or firm. And soft swelling could be also malignant, in case like I told in papillary carcinoma there would be variegated consistency. Some swelling would be soft, some would be very hard. If there is any localized single swelling, for that the local warmth, tenderness, size of the swelling, site, extent, surface, consistency. A cystic swelling may look firm due to the tension within the cyst. A calcified swelling may also feel hard. You have to look at the mobility. Then you can do a sternocleidomastoid contraction test. In this, you tell the patient to contract the sternocleidomastoid muscle and then look. How to contract the sternocleidomastoid is you have to tell the patient to turn her head against the resistance provided by your opposite hand. Then the opposite sternocleidomastoid will become prominent. Then you have to look whether the thyroid swelling become less prominent or becomes more prominent. Generally, thyroid swelling become less prominent on contracting the sternocleidomastoid, as thyroid is deep to the sternocleidomastoid muscle. After that, based on the same sternocleidomastoid test, you can do a chin test. You have to tell the patient to flex his or her head against the resistance provided by you on her chin. In this, sternocleidomastoid become little prominent and the thyroid swelling become less prominent because thyroid is under the sternocleidomastoid. Then you have to palpate for pressure symptoms. If both the lobe of thyroid are enlarged, then you have to do this Kocher test. Otherwise, no need of doing the Kocher's test in solitary thyroid nodule. In this, you have to hold both the lobes and press it toward the midline, and it will produce a stridor in case there is an obstructed trachea. Means Kocher's test is positive. One of the favorite question of examiners are what all are the contribution of Kocher in surgery. Kocher was actually the first surgeon to get Nobel Prize in 1909. He is also called as father of thyroid, a Kocher's incision which is used in cholecystectomy, Kocher's test which we recently just saw. There is Kocher vein which is the fourth vein of thyroid. There is Kocherization which means mobilization of first and second part of the duodenum. The next thing you have to look is you have to feel for carotid pulse. You have to remember that carotid pulse is felt at anterior border of sternocleidomastoid at the upper border of thyroid cartilage. You have to tell whether the carotid pulse is felt at normal side or not, or whether it is deviated or it is not felt. Generally, benign swelling will push back and deviate the carotid artery, but still the pulsation would be felt. But malignant thyroid swelling will engulf the carotid sheath completely and the pulsation will not be felt. That is called Barry's sign, and Barry's sign have great positive predictive value. If it is positive, so there are high chances of saying that thyroid swelling is malignant. So there is contribution of Barry in surgery is Barry's aneurysm, Barry's sign, just we saw Barry's ligament, which is a condensation of pretracheal fascia in posterior medial compartment. But there is Barry's picking, not done now. Then you have to look if sympathetic trunk is compromised because of thyroid swelling, then it will result into Horner syndrome, which will result into inophthalmos, means there will be sinking of eyeball into the orbit. There will be meiosis, means contraction of pupil. There will be anhidrosis, means there will be absence of sweating on the same side. There will be ptosis, means drooping of eyelid. You can also palpate for thrill. After the examiner, there is still a possibility that the thyroid swelling is having a retrosternal extension. Here what you can do is you can put your clinician can put his index finger on the lower border of thyroid and ask the patient to swallow. As soon the thyroid moves up, the lower border of the thyroid swelling is palpated. You have to palpate for trachea, which can be done by 3-finger test. You have to keep both the fingers in sternocleidomastoid joint, and you have to fall with your middle finger. You have to track the trachea and you have to look for any deviation or not. It can be also assessed with the stethoscope in the auscultation part. There is something called trial sign, means if the trachea is deviated to one of the side, then the prominence of sternocleidomastoid, the side where the trachea is deviated, it will become prominent, like in this picture. Then you have to palpate for cervical lymph node. Don't miss it, because if there is any malignancy of thyroid, then obviously some cervical lymph node would be palpable. If they are palpable, then you have to mention about their number, site, surface, margin, consistency, mobility. Just to mention that there's something called lateral aberrant thyroid, which is a misnomer, means like it will look like a thyroid swelling, but it is not a thyroid swelling. Instead, it is a lymph node which have enlarged because of metastasis of thyroid carcinoma. Then you have to do a measurement of circumference of the neck. You have to do at the most prominent part of the swelling. This is generally done to follow up the patient whether there is increase in the size of the swelling or not. Just remember, do not forget to palpate the isthmus palpation is important, and if there is a swelling in one side, you have to palpate in the opposite side also, because your diagnosis may change from solitary thyroid nodule to multinodular goiter. And also never do Pemberton test and Kocher's test in solitary thyroid nodule. So coming to the percussion, you have to percuss over the manubrium. You have to rule out the retrosternal extension of thyroid. Then on auscultation, you may hear a systolic bruit in the superior pole of the thyroid. This may be there due to increased vascularity, which occurs in primary thyrotoxicosis, means in Graves' disease mostly. Remember, you will never hear any bruit in the inferior pole of the thyroid, because as thyroid artery branches before it. Then you have to examine for any metastasis. Look for any metastasis in spine, cranium, lung, or ends of long bone. There could be a pulsatile metastasis seen in skull, which is commonly seen in follicular carcinoma of thyroid and also in renal cell carcinoma. Finally, you have to tell your diagnosis, anatomical finding, like whether it is solitary nodular goiter or multinodular goiter or diffuse goiter. You have to tell about the functional, whether it is toxic or euthyroid or hypothyroid state of the patient. You have to talk about the pathological diagnosis, whether it is a benign or malignant. Like for example, you have to tell this is a case of non-toxic multinodular goiter involving both the lobes and isthmus of the thyroid gland. If possible, try to mention the diagram, where is the swelling felt, how much size it is, mention in your diagram, whether the lymph node was palpable or not, that also you mention. Then just a little bit about, I want to talk about investigations, because there are a lot of investigations you have to do, like your chest x-ray to confirm the position of trachea. Before taking patient operation theater, you have to take indirect laryngoscopy to document the vocal cord status, and there are a lot of scan, isotope scan, technetium scan, and all those. I don't want to go into that detail, but just I want to mention that first investigation what you have to do is thyroid function test, because this is very important to know the status of hypothyroidism or hyperthyroidism. Because if the patient is having hyperthyroidism and you miss that and you send the patient for FNAC, then there could be chances of thyroid storm, and you have to do a USG before the FNAC, because if you do FNAC before, there are chances that during the FNAC there may be rupture of cyst. One disadvantage of FNAC of thyroid is it cannot differentiate between follicular adenoma, which is benign, and between follicular carcinoma, which is malignant. Just remember that biopsy is contraindicated in thyroid because of hemorrhage, because thyroid is very vascular, and there are chances of seedling can occur when you do a biopsy. To differentiate between follicular adenoma and follicular carcinoma, what is done is there is frozen cut section biopsy, means during the operation only a frozen cut section is taken from the thyroid and it is looked into microscope. Rest of the investigations you must go and check out in detail. Just a keynote, wherever you find a thyroid nodule with no lymph node palpable, then you can give your diagnosis as solitary thyroid nodule. Wherever there is a diffuse goiter and there is toxic symptoms, then mostly the diagnosis is grave disease. If there is solitary thyroid nodule with toxic symptoms, the diagnosis could be toxic nodule of thyroid. If there is solitary thyroid nodule with lymph nodes are palpable, mostly it is carcinoma of thyroid, mostly papillary carcinoma. Just remember that half of the solitary thyroid nodule are actually the presentation of dominant nodule of the multinodular goiter. Here I would like to discuss some important scenarios. If any other nodule is found by the examiner other than the solitary thyroid nodule, like if in the thyroid you found this nodule and your diagnosis solitary thyroid nodule, but the examiners makes you palpate again the thyroid and he found another nodule on the other side, then the diagnosis won't remain as solitary thyroid nodule, it will become multinodular goiter. If lobectomy is done for solitary thyroid nodule and the report comes as papillary carcinoma, then what we will do? So there are two options. If the patient age is less than 40, tumor size is less than 1 centimeter, it's a unifocal, intrathyroidal and well differentiated carcinoma is there, then lobectomy is enough, you don't have to revise the surgery. But if the patient age is more than 40, tumor is more than 1 centimeter, multifocal, extrathyroidal, not well differentiated, then you have to do a second surgery to do a total thyroidectomy. Next question is, after hemithyroidectomy, if report comes as follicular carcinoma, then what you do? If it is a minimal invasive carcinoma, then you have to give the full suppression of levothyroxine and follow up the patient. If it is frankly invasive carcinoma, then again you have to do a complete thyroidectomy. If after the total thyroidectomy, blood supply to the parathyroid is compromised, then what do? If the blood supply is compromised to the parathyroid, then they appear dusky after 20 to 30 minutes. Then what is done is parathyroids are removed, they are cut into fragments and they are implanted into sternocleidomastoid or non-dominant hand. The first symptom of hypoparathyroidism is paraoral numbness. So next question is, if the patient is having MEN2A syndrome, where the patient is having pheocytochroma and medullary carcinoma of thyroid, then which do you operate first? So the answer is, first we have to operate pheochromocytoma to avoid the hypertensive crisis during the surgery. I would like to discuss some extra diagnosis. First is Hashimoto thyroiditis. In this, it is chronic autoimmune. There will be painless anterior neck mass which would be symmetrically enlarged, would be soft to firm and non-tender. In later stages, the patient will have feature of hypothyroidism. Diagnosis will be confirmed by high titers of thyroid antibody in the serum. Second is grave disease. You can remember the mnemonic is goiter. It will have goiter, ophthalmic symptoms, irritability, tremors, restlessness, excitability, and also during the auscultation you will be able to hear a bruit over the thyroid swelling. The Quervain's thyroiditis, in which It will be post-inflammatory response. Patient would be generally females. The swelling would be firm, irregular, enlargement with adhesions. Patient will have fever, malaise, pain in the neck. Renal thyroiditis. In this, there would be painless hard mass which would be irregular, fixed, non-tender, which will mimic like a carcinoma. Patient may have features of hypothyroidism, generally associated with autoimmune diseases. Infective thyroiditis, mostly caused by streptococci, seen in children, preceded by upper respiratory infection or otitis media. Patient will have severe neck pain, fever, adenophasia or dysphagia. Thank you for watching this video. Subscribe to my channel for more videos. Follow on Facebook. See you guys in my next video. Tata, bye bye.